So I'm the last of the last. So thank you guys for sticking through. It's been a really great day. And I have to say, first of all, thanks to everyone for all your great talks. And I want to let you know that if I fail to mention any of your work, it's not because I don't think it's great. I just I tried to condense my comments in a 15-minute talk. I want to thank Carlos and Andrea and the organizers for putting this together. I've learned a lot today, and I think we have a lot to share further. Now, Carlos gave me the really easy task of trying to bring things together and put a sort of, I'm thinking that he wanted a clinician's perspective, that someone that deals with the issues of bedside dementia back all the time in other disorders I take care of, and who has become involved in acute flaccid myelitis through the clinic, and then in collaboration with some other scientists. These are my disclosures, and what I really want to talk about today is to talk about gaps, pitfalls, and barriers, to talk about some future translational thoughts, and to really discuss the concept of translational medicine, because as Carlos pointed out in his questions, we have learned so much in the last few years about flaccid myelitis. There have been lots of animal models and a lot of information on human what happens in people, but we're not quite there. And in terms of what to do. And a lot of it has to do with the size of the patient population, the age, and a lot of the things that even Ken talked about earlier with his mouse models. I'm taking us all back to the clinic, and all of us will be familiar with a child like this who came in and who looked perfectly well. I can turn the volume down a little bit so that you guys can see. So you can see this child, anyone who's a neurologist or a pediatrician can see that this child looks actually very healthy. But what's exceptional about her is that she has proximal weakness. She's unable to lift her arms. And in fact, her parents, interestingly, brought her in because she was unable to move her arms, but she was otherwise well. In our own clinical space, when she came into the hospital, she could do everything, and she was pushing buttons on the wall using her nose. I just got a message. Yeah. So if you look at her, she's a very typical case of flaccid myelitis, a well-looking child who has a severe spinal cord lesion that's centrally located, and which is a pure motor phenomenon. As Charles alluded to earlier, it's very hard to make a diagnosis, a viral diagnosis early on, and based our diagnosis, as we all know from the past few weeks of Symposium, is based on diagnostic criteria from MRI and other things. Now, we all know that in 2012 and then 2014, there were large clusters in Canada, 25 cases. That's a lot for us. And then in 2018, again, the cluster appeared elsewhere in Canada. We had a lot of cases in Toronto and then elsewhere. And so based on clinical observations, as Priya and everyone else showed, we all noticed that flaccid myelitis was occurring in clusters. MRI appearances seem to be different from other TM, and the organism, as everybody has pointed out, is rarely isolated in the CSF, and there were high rates of ICU stays. And so the question, and I think this is the question that Carlos posed and everybody in the symposium has posed, is how do we move from this clinical observation to the bench and back again? What I'm going to do is just sort of quickly summarize some of the information that has been made available, and to talk a little bit about what clinical translation pipelines are usually like. You have a clinical problem, you then have an animal model that goes to animal research, translating to human studies, phase 1, and success moving on to phase 2 and phase 3. And as Matthew just showed in his wonderful work, he hopes to go to a phase 1 study here, and we're doing that with other agents as well within the MS community. So this is a common pipeline. But the problem is the valley of death. And that's that whenever you get to, you may have failures either at the animal research stage, you might have a translational problem in phase 1, or a problem in phase 2 and phase 3, and your project dies or your idea dies. And when you think about it in this way, it's traditionally been a very straight arrow. But hopefully with the newer large teams that have been formed, and especially with the team that has been developed under essentially under the AFM banner, there will be more close collaboration and more feedback. And in fact, the better model of this kind of thing is to do just as has been done within the AFM group. It's to move to large collaborative initiatives with shared goals, multi-site and multi-lab collaborations, data science integration. No one has talked about data science and the use of data science in understanding this disorder, but that's something very important for us to move through. And then rapid trial preparation from data results. One of the issues we face in this disorder has been raised by everyone, and that is, by the time we see the children, they are far into their neurologic illness. And almost all of the models up until now are predicated on the assumption that direct viral infection is causing the problem. Yet we never pick up the virus. This has been emphasized by everyone so far. The feedback loop should mean that results feedback to the lab and clinical practice, and then we go back around and around. So how are we doing in AFM? We've heard a lot about mouse models, observations related to neurotropism, talk about neurotropism versus neurovirulence, and interventional models. And in fact, as we all saw earlier in the beautiful work that was presented earlier in the afternoon, a mouse model does exist. And Ken has done a lot of important work. Ken and others, many other people have been interested in this question, asking the question of, in particular with D68, of how that virus can enter and cause a problem and what the associated problems are. It's important to note, and I noticed that Kevin asked this question, that although a lot of work has been done, there is the paradox that this virus has been around since the early 60s, yet something happened in 2012 or 2014 to make the problem a public health problem. I've been in practice in neurology for a few years, and I can say that it's very clear that we did have a few sporadic cases of what looked like flaccid myelitis during my career prior to 2014, but none to the extent that we saw. There were certainly a few cases in 2008, for example. So what about pathogen discovery? And this is what Charles covered and sort of spoke about importantly. And these two papers have been referred to multiple times during the symposium. But it's just to remind everyone that not only that EVD68 and EV has been picked up in these kids, but the flip side of it, and this was really emphasized by Charles, is that, although it's been picked up, it's actually exceedingly difficult to pick up. And we don't know why it's so difficult to pick up. Importantly, Amy referred to the issue of the respiratory tract as being the initial point of interaction with the organism, and the link between the respiratory system and the neurologic system is still unknown. I think we need to say that we've spent a lot of time during this symposium talking about viral elements and some time talking about immune elements. And maybe it's time to really put those together. Let's go back to the patient. Does this make sense in clinical context? And really what I'm asking the question of is, should we be talking more about immune elements? Or host viral elements as host pathogen elements, as was alluded to in the first set of symposia. These are some results from our study of the flaccid myelitis cohort in Canada. There were 50 some odd cases. We're just talking, this particular group is the group that we were able to study more closely, because they were in Toronto. And what became clear to us when we were looking at our data is children where you could pick up pick up EV from a sample, a peripheral sample, were much more likely to have severe outcomes. These kids all presented it at the same time. We're assuming they had the same viral pathogen, but those in whom we could pick up EV had worse outcomes. They had worse EDSS. They had worse EDSS, which is the disability score, so more weakness, and they had worse outcomes and poor response to therapy. Contrary to what was found within the mouse model, we didn't find any differences in our populations between those that received IVIG and those that received steroids and those that received plasmapheresis, and that's just to speak to the messiness of human data and of the human system. So we saw beautiful work done by all of the groups that have spoken up until now, looking at response to therapy, but those were very controlled experiments in which you were able to inoculate with virus and watch for the number of days and to treat at different points. Yet there's something very special about these kids, as referred to by Priya, that made them respond differently. And we don't really know in reality what the response to different immunosuppressive therapies are. We did find that the largest difference in outcome was in who was EV positive in non-sterile sites. And that was the only thing we could see that could make a difference, that made a difference, leading us to wonder whether the most important, not the most important, but a very important issue was that of host virus factors. So it really just makes me think more and more, and we all think this, but I just want to emphasize that we need a greater integration between human and animal models so that they inform one another. About the same time that all of this was happening, we had the fortune of having a new scientist join us at Sick Kids, Julia Muffat, who has a specialty in building organelles and organoids to study neuroimmune interactions. And so our question was similar to what Amy was talking about and Ken was talking about and all the others were talking about, is can a peripheral trigger lead to CNS neuroinflammation? And is it something about the host environment together with the virus that would make a difference? So right now, Julien is working on developing organoids, and he has the ability to make cerebral organoids now where he will include microglia in them and run experiments on them using tissues from affected individuals. And so he's done this in Zika virus, he's done it in SARS-CoV, and also in models like ALD. What we proposed to do together was to consider making an organoid which is spinal cord specific, because as Carlos pointed out in his questions, there seems to be a predilection for the spinal cord. So we wanted to know, is there something special about the spinal cord? He's able to create models, a gut-brain axis on a chip, where we can study the vascular compartment in relation to the our question was related to the enteric nervous system because of some work that's been done in MS, but a similar question could be asked of the respiratory system. And in another, the proposal is to study the relationship between inoculation with enterovirus with organoids to evaluate the immune response and to see the relationship between the peripheral tissue and the central nervous system tissue in relation to this. So back to our patient. How did she do? And this, I really want to emphasize this. This to me emphasized the heterogeneity of patients and how little we know as clinicians. And hopefully I'll be able to show you this video, because there she is, just 3 to 6 months later. And I actually talked to Kevin about this case because of his report of all of the A71 cases. Was this A71? I don't know. We weren't able to pick it up, but look how wonderful she looks. We might have thought that it was something we did. I don't know if it was anything we did. I just have my own feeling as a clinician is so far the animal models are not able to predict this outcome. We really have a lot to learn. So we have lots of problems to solve. We need to really understand the mechanism of injury. That's been raised a lot already. We need to talk about treatment. And Ken mentioned this earlier, but it's really important for us to understand how to do a trial in these children. It's almost impossible from my perspective because we can't catch it early enough. But I think it's something that we need to discuss. And it's also very rare. 20,000 people get enterovirus infection children, 10 will get AFM, if that. And then prevention, looking for risk factors, genetic factors are important. The considerations I think are really important are the real need for collaborative teams. This has been a success as far as I'm concerned. The team that has been spearheaded by Carlos. And I think it's really important for us to break down barriers. I know that there are a lot of barriers within academic institutions. There's a lot of secrecy from scientist to scientist. And I hope that this group can avoid that kind of thing. I do think no one has talked about precision medicine. It's overused, but I think we need to think about these issues. How can we be very specific in our approaches to children so that we can have the best outcomes possible? And what has not been talked about, but is really important to understanding all of these things, is the harmonization of data sets, platforms, and collection protocols. Super important. These are my acknowledgements. These are our masked. This is my masked team, unmasked, standing at social distance. I just want to let everyone know that the next place to go is to go to the sessions area where there will be a Q&A. Thanks everyone for your attention, and I'll see you in the sessions area. Bye-bye.